Imagine for a moment that we had virtually eliminated infectious diseases. It sounds like something out of a science fiction novel, doesn't it?
It really does. A utopian dream, almost.
Yet, less than a lifetime ago, some of the most brilliant minds in medicine, they truly believed we were standing right on the precipice of that very accomplishment.
It's incredible to think about that level of optimism.
Welcome you to the deep dive. Today we're embarking on a pretty ambitious exploration, peeling back the layers of a truly foundational text in medicine, chapter 119 from Harrison's textbook.
Right, the one that lays out the basic considerations and the fundamental approach to infectious diseases.
Exactly. Our mission isn't just to, list facts. It's to equip you with an understanding of infectious diseases, the history, the challenges, the hidden complexities.
Through the lens of the elite professionals in this field.
Precisely. We're going to journey through the compelling history of how our understanding evolved, confront the staggering global impact these diseases still wield,
We're dive into that fascinating hidden world of our own microbiomes.
and then meticulously unpack the strategic playbook physicians use to diagnose and treat these constantly evolving challenges.
What's truly fascinating here, I think, is that this deep dive isn't exclusively for medical practitioners.
That's a great point.
While it's drawn from a core medical text, the insights we'll uncover are really for anyone who wants to grasp the fundamental forces shaping global health,
Uh-huh.
to peel back the complex layers behind the news headlines, or simply to satisfy a deep intellectual curiosity about one of humanity's oldest and, well, most persistent adversaries.
Yeah.
By the end of this deep dive, you'll have, I hope, a profound appreciation for the sheer complexity and the dynamic nature of infectious diseases.
And maybe, perhaps, a completely new perspective on your own body and the intricate microbial world that constantly surrounds us.
Exactly. It's quite a world.
Okay, let's unpack this incredible journey, starting at the very beginning, or rather, maybe a pivotal moment in our historical understanding of disease.
Sounds good. Where do we begin?
For centuries, the prevailing belief about how communicable diseases spread was rooted in what we now refer to as the miasma theory.
Ah, yes. Bad air.
Right. This idea, which held sway for a very long time, reaching back to at least the mid-16th century, it essentially blamed bad air for illnesses.
Think about it. If an area smelled foul, if there was decay or stagnant water, it was thought to be literally emanating disease.
It sounds almost quaint to us now, like something from a bygone era, doesn't it?
Totally. But this notion, despite being scientifically incorrect, it profoundly dominated medical thought for an incredibly long time.
And it influenced everything, right? Urban planning, medical treatments.
Everything. And that dominance persisted, shaping medical practice and public health until the late 19th century.
That era truly marked a pivotal turning point, wouldn't you say? A scientific revolution in our understanding of disease.
Absolutely. This was when the groundbreaking work of pioneers like Louis Pasteur and Robert Koch finally provided the credible, undeniable scientific evidence.
The evidence that displaced the miasma theory.
Exactly. They introduced what we now universally accept as the germ theory of disease, the radical, then revolutionary idea that invisible microorganisms directly cause infections.
Their meticulous research demonstrating conclusively that these tiny, unseen entities were responsible for illness. It fundamentally changed how we understood and approached disease.
It wasn't just a discovery, it was a complete paradigm shift.
A paradigm shift that, well, paved the way for monumental, life-saving progress.
And what truly remarkable progress that paradigm shift unleashed. The 20th century, armed with the germ theory, witnessed astonishing advances in the field of infectious diseases.
Once we understood that specific microbes were the culprits, scientists were able to rapidly identify the specific etiologic agents, the actual bacteria, viruses, fungi behind countless diseases.
That foundational step was critical. But then came the true game changers, discoveries that arguably transformed human civilization.
You mean antibiotics and vaccines?
Precisely. The advent of antibiotics and the widespread development of vaccines. Antibiotics at one point were literally viewed as a panacea.
A miracle cure.
Yeah, a miracle cure that could vanquish bacterial infections with seemingly effortless ease. Combined with vaccines, these innovations dramatically altered the landscape of human health.
Extending lifespans, preventing widespread suffering.
Absolutely. To truly grasp the scale of this success, you only need to consider the global elimination of smallpox.
An almost unimaginable triumph in public health.
It really was. Smallpox was one of the greatest scourges in the history of humanity, responsible for untold suffering and death for millennia.
So its eradication in the 20th century. It was a monumental historic achievement. It showed humanity's profound capacity to overcome even the most formidable microbial foes.
If we connect this truly inspiring period of success to the broader scientific and societal picture, these victories fostered a period of immense optimism, maybe bordering on outright hubris.
Yeah, you can see how that might happen.
This confidence prompted a truly influential immunologist and Nobel laureate, Sir Frank McFarlane Burnett, to make a profoundly audacious statement in his 1962 publication, Natural History of Infectious Diseases.
What did he say?
He wrote, and I quote, "In many ways, one can think of the middle of the 20th century as the end of one of the most important social revolutions in history, the virtual elimination of infectious disease."
Wow. Virtual elimination. That captures the sheer confidence, the almost boundless exuberance of that era, doesn't it?
It really does. The prevailing belief was that we had, effectively, won the war against microbes, that the age of infectious disease was rapidly drawing to a close.
Absolutely. It's almost mind-boggling to reflect on that level of confidence now, knowing what we know about the dynamic nature of microbes.
Right.
And that sentiment wasn't isolated to Burnett. Robert Petersdorf, another highly renowned infectious disease expert and a former editor of the very Harrison's textbook we're delving into, he echoed this optimistic view in 1978. He famously stated, and this is a striking quote, "Even with my great personal loyalties to infectious diseases, I cannot conceive a need for 309 more graduating trainees in infectious diseases unless they spend their time culturing each other."
Wow. So he genuinely believed the field was shrinking, that the need for infectious disease specialists would simply diminish.
He was, in a sense, writing the obituary for a specialized medical field.
And this is where the story takes a fascinating, almost ironic twist.
How so?
Because Dr. Petersdorf's statement, while seemingly short-sighted at the time, was ironically, almost clairvoyantly, prophetic in a way he couldn't have possibly foreseen.
He couldn't have imagined the reason. Right.
Exactly. But his mention of culturing each other almost perfectly foreshadowed the enormous growth of interest in the human microbiome over the past, 15 years or so.
Ah, that's a brilliant connection.
This groundbreaking new understanding of the vast microbial communities living within and on us has indeed created an unprecedented need for infectious disease specialists and researchers.
Albeit for reasons that were utterly unimaginable back in 1978.
Precisely. It's a testament to how quickly scientific understanding can evolve and reshape entire fields of study.
That unexpected evolution sets us up perfectly for the unforeseen onslaught we've experienced since that era of supreme confidence. Clearly, even with all the incredible advances of the 20th century, infectious diseases continue to represent a formidable, ever-present challenge for patients and physicians alike.
The dream of virtual elimination was, sadly, profoundly premature.
So what really happened? What went wrong with that prediction?
Well, the short answer is the microbes adapted, and our understanding deepened significantly.
Okay.
During the latter half of the 20th century, a surprising reality emerged that fundamentally challenged our previous assumptions. Several chronic diseases, which we had long considered non-infectious.
Right, things like ulcers or certain cancers.
Exactly. They were conclusively demonstrated to be directly or indirectly caused by infectious microbes.
Like Helicobacter pylori.
That's perhaps the most notable example, yes. The association of H. pylori with peptic ulcer disease and even gastric carcinoma.
And HPV.
Human papillomavirus, HPV, with cervical cancer.
Yeah.
And hepatitis B and C viruses with liver cancer.
This was a true revelation, wasn't it? It forced us to rethink the very nature of chronic illness and the complex interplay between microbes and human health.
Completely. It blurred the line.
It's truly astounding to consider the scope of that discovery. To put a quantifiable number on it, approximately 16% of all malignancies worldwide are now known to be associated with an infectious cause.
16%. Think about that. Roughly 1 in 6 cancers potentially linked back to a microbial culprit.
It's huge. And beyond these surprising connections to chronic disease, we've also seen a continuous, relentless rise of numerous emerging and re-emerging infectious diseases.
Yeah, ones that continue to have a dire impact on global health.
Just consider the profound societal disruption caused by HIVs.
A generation-defining illness.
SARS-CoV-2, the virus behind COVID-19.
Which shut down the world.
Ebola, Zika. These are just a few powerful examples of how new or previously controlled threats continue to reshape our world.
And the challenges don't end there. Adding to this persistent struggle is the ever-present, chilling fear of weaponizing pathogens for bioterrorism.
That poses a potentially enormous and catastrophic threat to public health, requiring constant, unwavering vigilance on a global scale.
Absolutely. But perhaps even more insidious, and certainly far more pervasive in our daily lives, is the escalating antimicrobial resistance in clinically relevant microbes.
The superbugs.
Essentially, yes. That panacea of antibiotics, once thought to be an unstoppable weapon against infection, is now facing critical erosion and requires incredibly thoughtful, appropriate stewardship.
We're seeing drug-resistant organisms like carbapenem-resistant Enterobacteriaceae and Acinetobacter species, bacteria that are incredibly difficult to treat.
Right, resistant to our most powerful antibiotics. Then there's Candida auris, a fungus emerging as a serious global health threat.
And drug-resistant Mycobacterium tuberculosis.
Still a huge global problem.
Right.
And vancomycin-resistant enterococci, or VRE.
These are just a few of the silent but incredibly dangerous threats that are eroding our ability to treat common infections.
They're forcing physicians to constantly adapt their strategies, constantly look for new approaches.
So, what does this dynamic and often humbling reality mean for us?
It means that for all these complex reasons, from the surprising links to chronic disease to emerging global threats, and the erosion of our antibiotic arsenal infectious diseases continue to exert grim effects.
On individual patients, yes, but also on international public health.
Exactly. Despite all the successes of the past century, the struggle against infectious diseases is not only dynamic and ongoing, it's arguably escalating.
Requiring physicians and public health professionals to be as thoughtful, innovative, and strategic now as they were at the very beginning of the modern medical era.
The war, as they say, is far from over.
Now, let's shift our focus from the historical battle to the current interconnected global reality, because infectious diseases are profoundly intertwined with every corner of our world.
They really are. No respecter of borders.
Here's a stark fact that truly underscores their enduring burden. Infectious diseases remain the second leading cause of death worldwide.
Second leading cause. That's significant.
While we've seen remarkable progress in reducing the rate of infectious disease-related deaths over the past 25 years or so,
There has been progress, yes.
we saw a staggering 10.3 million such deaths in 2017 alone.
10.3 million. That's a sobering reminder that despite all our advances, the microbial world is still a dominant force.
What's absolutely crucial to understand is that these deaths do not affect everyone equally. The burden is profoundly disproportionate.
It hits vulnerable populations hardest.
Primarily children under 1 year of age, adults older than 70 years, and critically, persons living in low and middle income countries.
To give you a picture of this disparity, while approximately 18% of all worldwide deaths were related to infectious diseases in 2017,
Which is already high.
that rate soared as high as approximately 58% in sub-Saharan Africa.
58%, that's more than half.
It isn't merely a statistical difference, it represents a profound regional inequality in health outcomes, a stark divide that highlights global health injustices.
Our sources actually provide compelling figures that help us truly visualize this magnitude and disparity. Imagine charts, for instance, showing the absolute number and the rate of infectious disease-related deaths globally since 1990.
Right, illustrating the trends over time. The progress, yes, but the persistent challenge, too.
Then another chart clearly illustrates the age-specific rates of these deaths in 2017, unequivocally showing those particularly vulnerable populations.
Very young and the elderly.
And finally, a global map, color-coded to show country-specific death rates attributable to communicable diseases, alongside maternal, neonatal, and nutritional disorders in 2017.
These visuals powerfully underscore the sheer scale and the disproportionate nature of the global health problem we're discussing. They make the abstract statistics come alive.
This profound disparity brings us to a key concept that elite professionals must master: understanding the local epidemiology of disease.
Right. Context is everything.
It is critically important in evaluating patients because knowing what infections are prevalent in a specific region drastically narrows down the diagnostic possibilities.
And crucially, helps physicians develop appropriate differential diagnoses and, consequently, highly effective, targeted treatment plans.
Without this local context, a physician is essentially flying blind.
Completely. You need to know what's common around here.
To give you some concrete, vivid examples of these regional hotspots, HIV/AIDS, for instance, has tragically decimated sub-Saharan Africa,
Mm.
with HIV-infected adults representing a staggering 20–23% of the total population in countries like South Africa, Botswana, and Lesotho.
That's not just a health crisis, it's a societal one.
Yeah,
Generational impact.
absolutely. Another grim example is drum-resistant tuberculosis, which is rampant throughout the former Soviet bloc countries, India, China, and South Africa.
Posing an immense challenge to global public health efforts.
This type of nuanced, geographically specific information, readily available through global health data, empowers physicians to make targeted, effective decisions.
Decisions that can literally save lives and guide resource allocation.
Programs like the Global Burden of Disease are absolutely invaluable here, aren't they?
Incredibly so. They seek to quantify human losses, not just deaths, but also disability-adjusted life years, or DALYs.
Which measure the years of healthy life lost due to premature death and disability.
Exactly. They quantify this burden due to various diseases by age, sex, and country over time. These aren't just academic exercises. They have profound real-world implications.
So this meticulously collected data, it not only helps inform local, national, and international health policy,
Guiding where resources and public health efforts should be strategically focused.
but it can also directly help guide local medical decision-making for individual patients, enabling more precise and effective care.
It connects the global picture right down to the bedside.
And here's where our world truly shrinks, revealing an even deeper layer of interconnectedness.
You mean travel?
Exactly. Even diseases that might seem geographically restricted, confined to specific regions, like pandemic influenza or Middle East respiratory syndrome, MERS.
They are now an immediate global concern.
Why? Because of the increasing ease and speed of rapid worldwide travel, a flight from one continent to another can take mere hours.
Raising significant concern about the swift, often unseen spread of pathogens around the globe.
It's not a new phenomenon, though, is it?
Not at all. History offers us countless, often tragic, precedents for this. Human migration and interconnectedness have, sadly, always been powerful vectors for epidemics.
Like Yersinia pestis.
The bacterium responsible for the Black Death, yeah. It systematically spread along ancient trade routes in the 14th century, devastating populations across continents.
Or think of the devastating impact of smallpox and measles imported by European explorers in the 15th and 16th centuries.
Tragically decimating Native American populations who had no prior immunity.
Military maneuvers also famously facilitated the rapid, widespread dissemination of the 1918 influenza pandemic.
A global catastrophe. And even religious pilgrimages, like the Hajj, drawing millions from across the globe to a single location, have historically provided means for the worldwide dissemination of diseases.
The patterns are clear and persistent.
But perhaps the best and most recent vivid illustration of travel's profound and undeniable impact on disease spread is the SARS-CoV-2 pandemic.
Absolutely. First identified in Wuhan, China, this virus carried by travelers quickly and relentlessly spread across the globe.
Leading to an abrupt halt of virtually all international travel and commerce.
Economies plunged into deep recession, and at one point, over half the world's population was living under unprecedented stay-at-home orders.
It was a stark, unprecedented demonstration of global interconnectedness and the devastating power of a rapidly spreading pathogen.
And the mechanisms behind this rapid spread are quite clear, right?
Oh yes. Travelers can easily carry person-to-person transmitted infections, like influenza, measles, or HIV, across continents in a matter of hours.
They can also, perhaps less intuitively, introduce vector-borne infections
Like chikungunya and Zika viruses.
to new geographic areas where the mosquito vectors might already exist, creating new hotspots.
And importantly, global travel contributes significantly to the worldwide spread of multi-drug-resistant organisms, as resistant strains can hitch a ride with asymptomatic carriers.
So this increasing interconnectedness of our world has profound and often challenging implications.
Not only for the global economy, but also, and perhaps most critically for our discussion today, for global medicine and the relentless spread of infectious diseases.
Now let's take an incredible journey inward to the hidden world that resides within us, a complex ecosystem that profoundly influences our health and susceptibility to disease.
The microbiome, it's such a fascinating area.
This is truly an aha moment for many people when they first encounter it. Do you know that normal, healthy humans are colonized with an astonishing approximately 50 trillion bacteria?
50 trillion, and that's just bacteria.
Right. We also host countless viruses, fungi, and archaea. To put that in perspective, these microorganisms collectively outnumber our own human cells by about 10 times.
Imagine that. A bustling, incredibly diverse ecosystem residing right there within your body. It's not just us, it's us plus them.
So where are these microbes mostly found?
The major reservoir for these incredibly numerous microbes is, perhaps unsurprisingly, the gastrointestinal tract.
The gut.
Exactly, where they play crucial roles in digestion and nutrient absorption. However, substantial numbers also live in other key areas, including the female genital tract, the oral cavity, and the nasopharynx.
And our understanding is still expanding, right?
Oh, definitely. There's increasing interest in the skin and lungs as significant sites where microbial colonization might be highly relevant to the biology and disease susceptibility of the host.
And these aren't just passive passengers taking up residence.
Not at all. These commensal organisms are good microbes, provide the host with a myriad of benefits.
Like,
From aiding in metabolism, helping us digest food and extract vital nutrients, to critically shaping the development and ongoing function of our immune system. They are, in essence, essential partners in our health.
but here's where our traditional understanding of germs truly gets reframed, and it's a crucial point for grasping the professional's perspective.
Right. It's not always about outside invaders.
When we think about infections, we often conjure images of some foreign invader, a microbe from outside. However, the vast majority of infections are actually caused by organisms that are already part of our normal microbiota.
Like Staphylococcus aureus, which often lives harmlessly on our skin and in our noses.
Or Streptococcus pneumonia, which can reside in our upper respiratory tract.
Or Pseudomonas aeruginosa, commonly found in our environment and sometimes on us.
So relatively few infections are due to organisms that are strictly pathogens, meaning they only cause disease.
Exactly. Things like Neisseria gonorrhea or the rabies virus. This profoundly changes how you view the germs you carry every single day.
They are often our own residents, simply in the wrong place or at the wrong time.
Precisely. Where the balance gets disrupted.
This deeper understanding of the human microbiota has major clinical relevance for physicians, doesn't it?
Huge relevance. An individual's unique microbial community has a major impact on their susceptibility to infectious diseases.
Uh-huh.
It can even influence their responses to vaccines.
Really? How so?
Well, for example, the composition of your gut bacteria can affect how well your immune system responds to certain immunizations. It's quite complex.
So for physicians in practice, site-specific knowledge of the indigenous microbiota facilitates what?
It facilitates the appropriate interpretation of culture results, helping them distinguish between a true infection and mere contamination from the body's normal residence.
Okay, so telling a real threat from just a bystander.
Right. It also profoundly aids in the selection of empirical antimicrobial therapy.
Meaning the initial antibiotic choice before you know the exact bug.
Yes. It guides the choice of antibiotics based on the most likely causative agents for a given infection in a particular body site.
And perhaps, most importantly,
This knowledge provides additional impetus for rational antibiotic use, minimizing the untoward, often damaging effects of these powerful drugs on the beneficial microbes that inhabit the body. It's about preserving that vital inner ecosystem.
protecting the good guys while targeting the bad guys.
That's the goal.
So with all these microbes around and within us, and given that many infections arise from our own microbiota, how do they actually cause disease?
The pathways of entry and pathogenesis. This brings us to the crucial steps, integrating insights from Chapter 120 of Harrison's as well.
Okay.
At its essence, infectious diseases occur when either a live pathogen enters the human host.
Or a toxic product produced by a pathogen is ingested by the host.
Right, but the entry of a live pathogen is by far the much more common scenario.
So the complex process of infection from a professional standpoint can be broken down into several distinct but interconnected stages.
Yes. First, there's the encounter and entry, often referred to as colonization.
This is the moment the microbe gains access to the human body.
Exactly. This typically happens through a break in the skin, allowing entry into the underlying soft tissues, or at the surface of a mucous membrane, respiratory, gastrointestinal, genitourinary tracts.
Direct infection of the skin itself is also possible, right? Like fungal infections?
Sure. And entry at these initial sites can then lead to a more widespread infection, particularly if the pathogen enters the bloodstream.
Which can then spread to other vital organ systems throughout the body.
Correct. Once inside, the next crucial stage is attachment and avoidance, or what we call infection.
Here, the microbe, having gained entry, actively seeks out its favored niche within the host.
It does. It then works diligently to attach itself to host cells and, crucially, to evade the host's sophisticated defense mechanisms, establishing a foothold.
After that, we enter the damage and response stage. This is when the actual disease manifests, leading to symptoms.
And importantly, this isn't solely about what the microbe does to us. It's a complex interplay,
It's a combination of microbial factors that directly damage human tissue.
coupled with the host's own inflammatory responses to the presence of the microbe.
It's profoundly important to remember that our own inflammatory response, our body's attempt to fight the invader, often contributes substantially to both the symptoms we feel like fever and pain and the actual tissue damage that occurs.
Absolutely. Friendly fire, in a way. Finally, there's the stage of release and transmission.
Where the pathogen, having established itself and caused disease, then spreads into the environment to infect others.
Perpetuating its life cycle and the chain of infection.
And here's where the profound concept of the human microbiota, that vast collection of microbes residing in and on our bodies, ties back into every stage.
Yes. Our microbiota modulates, directly or indirectly, every single one of these infection processes, from initial encounter and entry to disease manifestation and transmission.
It's an incredibly complex, dynamic dance between host and microbe, where our own microbial residents play a crucial, often underappreciated role.
A very intricate dance.
Let's delve a bit deeper into some of the most common pathways of entry, starting with the respiratory tract.
Okay. Microbes typically enter here via respiratory droplet nuclei, those tiny, invisible airborne particles, typically 1 to 5 micrometers in diameter.
Or they can enter through fomites, which are contaminated inert surfaces, like a doorknob.
Right. You touch the fomite, then inadvertently transfer the microbes to your mouth, nose, or eyes.
How are these droplet nuclei generated?
They're generated when an individual with a communicable respiratory infection engages in activities that expel air sneezing, coughing, talking.
Even playing a musical instrument or singing.
Yes. To give you an idea of the sheer scale, a single cough can generate around 3,000 particles,
Wow.
whereas a sneeze may generate up to 40,000 particles.
40,000.
And what's more, larger particles, after being expelled, may rapidly evaporate down to the smaller, more dangerous 0.5 to 12 micrometer range.
Allowing them to remain airborne for longer.
Exactly. And particles that are 1.5 micrometers and hygroscopic, meaning they absorb moisture, actually increase in size as they pass through the moist nasal passages and lower respiratory tree.
Which allows them to deposit more efficiently and deeply into the lungs.
Precisely. This mechanism explains how diseases like tuberculosis, Legionnaire's disease, psittacosis, influenza, measles, chickenpox, aspergillosis, and of course COVID-19 infection spread so effectively through the air.
Moving to the gastrointestinal tract, entry typically occurs via the ingestion of food or water that has been contaminated with pathogens.
Or through direct person-to-person contact, usually with transfer from a contaminated hand into the mouth.
It truly emphasizes the profound importance of basic hand hygiene, doesn't it?
Absolutely. Something so simple can have such a profound impact on preventing disease transmission. Understanding this is vital for public health.
What's also critical for professionals is understanding the concept of inoculum size, right?
Yes, the number of organisms required to cause an infection. Pathogens that require a large inoculum, for example, an astounding 10 to the power of 8 organisms for epidemic spread of Vibrio cholerae,
The cause of cholera.
or 10 to the power of 5 organisms for Salmonella enterica cerevar typhimurium, a common cause of food poisoning.
These are generally acquired via contaminated food or water, where large numbers of microbes can accumulate.
Correct. Conversely, pathogens that require a small inoculum, such as just 10 to 100 organisms for Shigella species,
A cause of severe dysentery.
are more commonly acquired through direct person-to-person contact,
This subtle but profound difference in inoculum size dictates transmission routes.
and consequently informs public health interventions and strategies for prevention. It tells you where to focus your efforts.
Okay, now let's step into the physician's mind and explore their playbook, how they approach a patient with a suspected infection. This is where the true detective work begins.
Absolutely. And it starts, as in all of medicine, with the art of taking a thorough patient history.
A complete and meticulous history is absolutely paramount in the evaluation of a patient with a possible infectious disease.
It's the critical first step for developing a focused list of possible diagnoses, the differential diagnosis, and for guiding the subsequent physical exam and initial diagnostic testing.
Without a good history, you're essentially looking for a needle in a haystack blindfolded.
Pretty much. We can effectively break down the history-taking process into 2 critical areas: especially when dealing with infectious diseases.
What are they?
First, there's the exposure history, which aims to meticulously identify any microorganisms with which the patient may have recently come into contact.
This includes asking about previous infections or, very importantly, any known exposure to drug-resistant microbes.
Critically important. Knowing if a patient has a history of infection with organisms like MRSA, VRE, or those ESBL or carbapenem-S-producing enterics.
The really tough bugs.
Right. Knowing that history can fundamentally alter the choice of empirical antibiotics.
For instance, if a patient presents with a severe bloodstream infection and has a known history of an invasive infection with a multi-drug-resistant Pseudomonas aeruginosa isolate,
Then the physician must treat them empirically with an antimicrobial regimen that covers that specific resistant strain immediately, potentially even before culture results are back. You can't wait.
and it goes far beyond just past medical history, extending into the patient's lifestyle. A truly comprehensive social history is also crucial.
Mhm. While physicians often limit this to inquiries about alcohol and tobacco use, a truly complete social history can offer numerous invaluable clues.
This means delving into whether the patient engages in high-risk behaviors like unsafe sexual practices or intravenous drug use.
Yes, but also critically include potential hobby-associated exposures, for instance. An avid gardener might be at risk for Sporthrix Schenke exposure from soil,
Causing skin lesions.
or occupational exposures, like funeral service workers having an increased risk for Mycobacterium tuberculosis exposure.
These details, seemingly unrelated to a current fever, can be the missing piece of the puzzle.
The profound importance of this seemingly simple line of questioning is powerfully exemplified by that tragic case from 2009.
The laboratory researcher,
Yes, who died of a Yersinia pestis infection acquired during his work with the bacterium. He had visited both an outpatient clinic and an emergency department.
but his medical records at both sites unfortunately failed to include his occupation.
Crucial information that potentially could have led quickly to appropriate, life-saving treatment and essential infection control measures. Because it was missed, the outcome was fatal.
It highlights the absolute necessity of a thorough social history.
It really does. It's also vital to inquire about dietary habits, as certain pathogens are strongly associated with specific foods.
For example, Shiga toxin-producing strains of E. coli and Toxoplasma gondii are linked to raw or undercooked meat.
Right. Unpasteurized milk can be a source of Salmonella typhimurium, Listeria monocytogenes, and Mycobacterium bovis.
Unpurified water carries risks of Leptospira species, various parasites, and enteric bacteria.
And raw seafood can be associated with Vibrio species, norovirus, various helminths, worms, and protozoa. Every meal can be a clue.
Then there are animal exposures.
Also critical. Because animals are frequently important vectors or reservoirs of infectious diseases, patients should always be diligently asked about any contact with animals.
Including their own household pets, visits to petting zoos or farms, or even random encounters, like a home rodent infestation.
All the above. For instance, dogs can carry ticks that transmit serious diseases, like Lyme disease, Rocky Mountain spotted fever, and ehrlichiosis.
Cats are associated with Bartonella henselae infection, causing cat scratch disease.
Reptiles, like turtles and snakes, are well known to carry salmonella. Rodents can transmit leptospirosis. Rabbits are associated with tularemia.
A seemingly innocent interaction with an animal can be the critical link.
Absolutely. And we absolutely cannot forget travel history, whether domestic or international.
Fever in a patient who has recently returned from abroad significantly and immediately broadens the differential diagnosis.
Puts a whole range of exotic diseases on the table. Even a remote history of international travel, perhaps years ago, may reflect exposure to persistent pathogens like Mycobacterium tuberculosis or Strongyloides stercoralis, which can reactivate later.
Similarly, domestic travel can expose patients to pathogens not normally found in their local environment.
Right, like a patient who recently visited California might have been exposed to Coccidioides immitis, valley fever.
Or Francisella tularensis, tularemia if they were in Martha's Vineyard. Geography truly plays a role in pathology.
But for the elite professional, it's not enough to just identify locations.
You need to dig deeper.
Much deeper. You need to learn what kinds of activities and behaviors the patient engaged in during travel. What specific types of food and sources of water did they consume? Did they swim in fresh water?
Any animal exposures, maybe mosquito bites in endemic areas?
Exactly. And crucially, did they receive the necessary immunizations or take prophylactic medications prior to travel?
Because that would offer protection against certain diseases.
Right. These additional detailed exposures, which a patient might not think to report without specific prompting, are just as important as the destination itself.
Okay, what's the second critical area of the history?
It focuses on host-specific factors that may predispose a patient to infection.
Like immune status.
Vitally important to determine the patient's immune status, especially since many opportunistic infections like Pneumocystis jirovecii, Aspergillus species, or JC virus primarily affect individuals with compromised immune systems.
Knowing the immune status immediately narrows or expands the list of likely culprits,
Precisely. Defects in the immune system can stem from various causes.
like underlying disease, malignancy, HIV, malnutrition.
Yes. Medications are also a very common culprit: chemotherapy, prolonged use of glucocorticoids, steroids, or specific monoclonal antibodies.
Certain treatment modalities, too, like total body irradiation or splenectomy.
Correct. Removal of the spleen is critical for fighting certain bacterial infections. And finally, some individuals are born with a primary immunodeficiency.
A genetic defect in their immune system?
Right. Understanding the specific type of immune defect helps predict the specific type of infection a patient is at increased risk for.
And in conjunction with assessing immunocompromise, the physician must also diligently review the patient's immunization record.
Absolutely. Ensure they are adequately protected against vaccine-preventable diseases. It's all part of the host picture.
Moving on from the history, a thorough and meticulous physical examination is equally crucial in evaluating patients with an infectious disease.
No shortcuts here.
It's often the case that elements of the physical exam, like the skin and lymphatics, are performed in a cursory manner in busy clinical settings.
Unfortunately, yes. But for infectious diseases, these seemingly minor areas can actually help significantly in identifying the underlying diagnosis, revealing subtle but vital clues.
Moreover, serial exams are critical, you said.
Extremely important. An infection is a dynamic process. New findings may appear or evolve as the illness progresses, providing continuous, updated clues that can dramatically shift the diagnostic approach.
Let's focus on some components of the physical exam with particular relevance to infectious diseases, starting with vital signs.
Okay, elevations in temperature are often a hallmark of infection, making close attention to it invaluable.
The idea that 37 degrees C or 98.6 degrees era is normal, that's a bit outdated.
It is. It dates back to the 19th century and was initially based on axillary measurements. Rectal temperatures, however, more accurately reflect the core body temperature.
And they're typically higher than oral or axillary readings.
About 0.4 degrees C higher than oral, 0.8 degrees higher than axillary. For precise diagnosis, understanding these nuances is crucial.
And this notion of a single normal temperature doesn't account for individual variations.
Not at all. Temperatures tend to be naturally higher later in the day, they can be higher in women, and generally they're higher in younger people.
And fascinatingly, the average human body temperature seems to have dropped slightly over the decades.
Approximately 0.03 degrees C every decade since the early 1800s, suggesting a new normal of around 36.7 degrees C.
So how do we define fever clinically?
The most common clinical definition, based on studies defining fever of unknown origin, is a core temperature of 38.3 degrees C or higher, 101 degrees Fahrenheit.
While fever is very commonly associated with infection, it's vital to remember it's also documented in many other non-infectious diseases.
Correct. It's a critical clue, but not definitive on its own.
You mentioned a specific phenomenon, pulse temperature dissociation, or Fagot's sign.
Yes, an intriguing vital sign clue. Typically, for every 1 degree C increase in core body temperature, the heart rate rises by 15 to 20 beats per minute.
Fagot's sign describes relative bradycardia.
Exactly, where the patient has a lower heart rate than might be expected for their body temperature.
While not highly sensitive or specific enough on its own to establish a diagnosis definitively.
It can be a tremendously useful clue, especially in low-resource settings, due to its ready availability and simplicity.
And this phenomenon is particularly associated with certain types of infections.
Yes, certain intracellular organisms like Salmonella typhi, typhoid, Francisella tularensis, tularemia, Brucella, Coxiella burnetii, Q fever, Leptospira, Legionella, Mycoplasma pneumonia.
Also specific tick-borne organisms.
Like Rickettsia, RMSF, Orientia tsutsugamushi, scrub typhus, and Babesia.
Other notable causes.
Corynebacterium and diphtheriae, Plasmodium, malaria, and various viral infections like yellow fever, dengue, some viral hemorrhagic fevers early on, and viral myocarditis.
This seemingly subtle vital sign deviation can point a seasoned clinician towards a very specific and often serious diagnosis.
It can be a very helpful hint.
Next, let's consider the lymphatics, the body's vigilant watchtowers.
There are about 600 lymph nodes distributed throughout the body, and infections are a primary cause of lymphadenopathy, or swollen lymph nodes.
A thorough physical examination should include meticulously evaluating lymph nodes in multiple key regions.
Popliteal, behind the knee, inguinal groin, epitrochlear near the elbow, axillary armpit, and multiple cervical neck regions.
And the physician meticulously notes their location size.
Mm.
What's normal size?
Generally less than 1 centimeter. Also, presence or absence of tenderness, and consistency soft, firm, or rubbery.
And whether the nodes are matted, meaning connected and moving together.
Right, which can indicate certain types of chronic infection or malignancy.
Nodes that are small and firm can also be described as shoddy.
Yes, like buckshot pellets. What's particularly noteworthy is that palpable epitrochlear nodes near the elbow are always considered pathologic.
Always indicate an underlying disease process, an immediate red flag.
Exactly. When patients present with lymphadenopathy, about 75% have localized findings confined to one region.
While the remaining 25% have generalized lymphadenopathy involving more than one anatomic region.
Localized lymphadenopathy in the head and neck region is most common, 55%, followed by inguinal, 14%, and then axillary, 5%. Yeah.
Determining whether it's generalized versus localized can significantly help narrow the differential diagnosis.
Definitely. Different infections have different patterns.
The skin is another profoundly crucial area, serving as a window to infection.
Absolutely vital. The fact that many infections have visible cutaneous manifestations gives the skin examination particular importance.
It's absolutely vital to perform a complete skin exam, paying close attention to both front and back, including areas often overlooked.
Specific rashes, with their unique appearance and distribution, can be extremely helpful, even diagnostic, in narrowing the differential diagnosis.
We've heard anecdotes about patients in the ICU with fever of unknown origin actually due to unrecognized puncture ulcers.
It happens, just because a complete skin exam wasn't performed or was done too superficially.
Moreover, a close examination of the distal extremities, hands and feet for specific subtle signs.
Like splinter hemorrhages under the nails, Janeway lesions on palm soles, or Osler's nodes on fingertip toes.
May yield critical evidence of endocarditis or other causes of septic emboli.
Subtle but absolutely critical clues.
Finally, considering the physical exam, it's vital to think about foreign bodies and breaches in our natural barriers.
Right. As we discussed, many common infections are caused by members of our indigenous microbiota escaping their normal habitat.
This underscores a fundamental principle. The maintenance of our epithelial barriers, skin and mucous membranes, is one of our most important protections.
But hospitalization is often unfortunately associated with numerous breaches of these barriers.
Medical devices like IV lines, surgical drains, or tubes like endotracheal tubes and Foley catheters.
They create direct pathways that allow microorganisms to localize in sites they normally wouldn't access.
So knowing precisely what lines, tubes, and drains are in place is incredibly helpful in ascertaining what specific body sites might be infected.
It points you towards potential sources.
Moving beyond the physical examination, we enter the realm of diagnostic testing.
Lab and radiology, indispensable components now.
The dramatic increase in sophisticated serologic diagnostics, antigen tests, and molecular diagnostics like PCR has truly revolutionized medical care.
Allowing for much faster and more precise diagnoses. However, it's crucial to remember.
They are adjuncts to the comprehensive history and meticulous physical examination, not a replacement for fundamental clinical reasoning.
Exactly. Tools, not answers in themselves. And the selection of initial tests should always be based directly on the patient's history and physical exam findings.
The art meets the science.
Right. Furthermore, diagnostic testing should generally be limited to those conditions that are reasonably likely and treatable.
Those important for public health, or those capable of providing a definitive diagnosis that limits other testing.
It's about a systematic, efficient approach. Avoids the shotgun approach.
Let's start with the white blood cell, WBC, count the body's cellular army.
Elevations in the total WBC count are often associated with infection, indicating an active immune response.
Though, interestingly, many viral infections can actually be associated with leukopenia, a lower than normal WBC count.
A key distinguishing feature sometimes. What's truly important is assessing the WBC differential, which breaks down the count into specific types of white cells.
Because different classes of microbes are associated with various leukocyte types.
Precisely. Bacterial infections often show an increase in polymorphin nuclear neutrophils, often with immature bands.
Viral infections commonly show an increase in lymphocytes.
And certain parasitic infections are characteristically associated with an increase in eosinophils.
Eosinophilia, specifically an elevated count of eosinophils, can be a crucial indicator.
Often pointing towards parasitic infections, but also allergic reactions or certain drug reactions.
There are different degrees: mild, moderate, extreme.
Yes, and they can correlate loosely with different types of infections. Mild eosinophilia, maybe chlamydia or anisakis. Moderate might suggest nothostoma or paragonomus. Extreme could point to Angiostrongylus, toxicara, or trichinella.
It's a broad list covering various organs, exposures, and geographies.
But it's critical to remember there are also numerous significant non-infectious causes of eosinophilia: allergies, drugs, malignancies. Careful interpretation is essential.
Moving to other inflammatory markers, we have ESR and CRP.
Erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. Indirect and direct measures, respectively, of the acute phase response.
Used to assess the general level of inflammation and monitor disease progress or resolution.
Exactly. What's noteworthy about their kinetics, how quickly they change, is a crucial distinction.
The ESR changes relatively slowly.
Right. Measuring it more often than weekly usually isn't useful for acute changes. In contrast, CRP concentrations change rapidly.
Making daily measurements potentially useful for tracking acute inflammation.
Correct. While both ESR and CRP are sensitive indicators of inflammation, neither is very specific.
They can be elevated in many conditions, not just infections.
But an extremely elevated ESR, specifically above 100 millimeters per hour, has a high predictive value, about 90%, for a serious underlying disease.
This could point to serious infections like endocarditis, deep abscesses, osteomyelitis, TB.
Or severe inflammatory diseases like giant cell arteritis, rheumatoid arthritis, lupus.
Malignancies like multiple myeloma, leukemias, lymphomas, carcinomas.
And other causes like drug reactions, tissue injury, trauma, renal disease. So even non-specific markers, when extremely high, become powerful clues.
Work is ongoing to identify other potentially useful inflammatory markers.
Like procalcitonin or serum amyloid A protein, but their clinical utility still requires further validation.
Next, analysis of cerebrospinal fluid, CSF, is absolutely critical for patients with suspected meningitis or encephalitis.
Inflammation of the brain or its surrounding membranes, and opening pressure should always be meticulously recorded during the lumbar puncture.
And the fluid should routinely be sent for cell counts, gram stain and culture, and determination of glucose and protein levels.
Right. A CSF gram stain typically requires a high bacterial load for positivity, but its specificity approaches 100%. If you see bugs, they're almost certainly there.
What's truly illuminating is how different infections produce distinct CSF profiles, almost like a unique signature.
Exactly. In bacterial meningitis, you typically see a very high WBC count, mostly neutrophils, PMNs, with very low glucose, high protein, and high opening pressure.
Common causes: Streptococcus pneumonia, Neisseria meningitidis.
In contrast, viral meningitis usually presents with a lower WBC count, mostly lymphocytes, with normal glucose, slightly elevated protein, and normal to slightly elevated opening pressure. Enteroviruses are common culprits.
Fungal, parasitic, or tuberculous meningitis tend to show moderate WBC counts with lymphocytes and low glucose.
Yes, but with varying protein levels and opening pressures. Tuberculous meningitis, for example, often has very low glucose and markedly elevated protein.
Encephalitis also typically shows lymphocytic pleocytosis, but often with normal glucose and slightly elevated protein.
Correct. Common causes include herpes viruses, enteroviruses, influenza. Understanding these distinct patterns is fundamental to rapid, accurate diagnosis.
What about bacterial antigen tests of CSF?
Like latex agglutination tests. Not recommended for screening, as they're generally not more sensitive than gram stain.
But they can be helpful in presumptively identifying organisms seen on gram stain.
Yes, giving a quicker preliminary ID. Other antigen tests, like for Cryptococcus, and certain CSF serologic testing, like for syphilis or coccidioids, are highly sensitive and extremely useful for select patients.
And PCR analysis of CSF?
Polymerase chain reaction. Increasingly used for rapid and accurate diagnosis of both bacterial infections, like N. meningitis, is pneumonia, mycobacteria, and viral infections, like HSV, enterovirus.
These molecular tests permit rapid diagnosis with high sensitivity and specificity,
Often providing answers within hours. However, a key limitation is that they often don't allow for determination of antimicrobial resistance profiles.
which is crucial for guiding effective antibiotic treatment. So, fast, but not the full picture for treatment strategy.
Exactly. Which brings us to cultures,
Still absolute mainstays of infectious disease diagnosis.
involving carefully growing microbes from infected tissue or fluids, like blood, urine, sputum, ponds.
Samples can be sent for culture of bacteria, aerobic or anaerobic, fungi, or viruses.
Ideally, for the most accurate results, specimens are collected before the administration of any antimicrobial therapy.
Because antibiotics can often make subsequent diagnosis much more difficult by suppressing or eliminating the pathogen.
Right. If obtaining a pre-treatment specimen isn't feasible, then microscopic examination of the specimen gram stain, KOH prep, becomes particularly important for immediate clues.
What critical information does culturing provide?
First, precise identification of the etiologic agents. Second, crucially, determination of the antimicrobial susceptibility profile which antibiotics work. Third, for outbreak concerns, isolate typing helps track spread.
While cultures are extremely useful, determining whether results are clinically meaningful or just contamination can be challenging.
Sometimes, yes, like a skin contaminant in a blood culture. This requires understanding the patient's immune status, exposure history, and microbiota. Serial cultures can sometimes help demonstrate clearance.
Beyond traditional cultures, there's also a wide array of pathogen-specific testing.
Numerous tests, serology, antigen testing, advanced PCR, many available commercially or developed in-house by hospitals for faster turnaround.
One challenge is that some advanced tests, like universal PCRs, can identify organisms that aren't easily cultivable and have unclear relationships to disease.
Yes, complicating diagnosis.
Okay.
But as these tests improve and the Human Microbiome Project progresses, the relevance of some of these previously unrecognized bacteria will likely become clearer.
Finally, radiology or medical imaging.
An important adjunct to the physical examination. Imaging allows evaluation of lymphadenopathy in inaccessible regions like the mediastinum or abdomen.
Also crucial for assessing internal organs for infection, identifying abscesses, inflammation, or structural changes.
And it can facilitate image-guided percutaneous sampling of deep spaces, obtaining precise specimens without major surgery.
The choice of imaging modality, CT, MRI, ultrasound, nuclear medicine, contrast use, is best made in consultation with a radiologist.
Absolutely. To ensure the results directly address the specific clinical questions. Collaboration is key.
Now that we've delved into the meticulous diagnostic process, let's pivot to the strategic response. Treatment, control, and expert guidance.
Right, putting the plan into action.
When it comes to targeting the enemy with antimicrobial therapy, physicians face a constant, delicate balancing act.
They must weigh the immediate urgent need for empirical antibiotic treatment with the patient's overall clinical condition and the available diagnostic information.
And there's a crucial, fundamental principle guiding this.
Whenever clinically feasible, it is always best to obtain relevant samples, blood, CSF, tissue, pus for culture, prior to the administration of antibiotics.
Because antibiotic treatment often suppresses or eliminates the pathogen, making subsequent diagnosis much more difficult.
Or impossible sometimes.
Yeah.
While a general maxim is to use a regimen with as narrow a spectrum as possible.
Targeting only locally pathogens to minimize side effects and resistance.
Empirical regimens, by nature, are necessarily somewhat broad, since a specific diagnosis hasn't yet been made.
Once a specific diagnosis is confirmed and susceptibility results are available, the regimen should then be precisely narrowed.
Yes, targeting only the identified pathogen. That's de-escalation.
Let's walk through some illustrative examples of empirical antibiotic treatment regimens for common presentations. Remembering these are broad guidelines.
And local resistance patterns are key. But for septic shock, a life-threatening condition. Common culprits are S. aureus, S. pneumonia, enteric gram-negatives.
The empirical regimen often involves vancomycin plus a broad-spectrum anti-pseudomonal beta-lactam.
Like piperacillin tazobactam, imipenem, meropenem, or cefepima. If Pseudomonas is strongly suspected, maybe even add a second anti-pseudomonal agent.
For meningitis, especially suspected bacterial.
Typically vancomycin plus ceftriaxone. Importantly, for suspected or proven pneumococcal meningitis, add dexamethasone.
With the first dose before the first antibiotic dose.
Critically important timing for better outcomes. For a CNS abscess, brain abscess, common etiologies include streptococcus, staphylococcus, anaerobes, gram-negatives.
So the regimen often combines vancomycin, ceftriaxone, and metronidazole to cover that broad range.
Correct. And for acute endocarditis on a native heart valve, typically caused by S. aureus, streptococcus, coagulase-negative staph, Vancomycin plus cefepime is a common empirical choice.
Pneumonia is another incredibly common scenario with different empirical approaches.
Depends on setting and risk factors. Community-acquired pneumonia in an outpatient, no comorbidities, maybe azithromycin.
With comorbidities, perhaps a respiratory fluoroquinolone like levofloxacin.
Inpatient non-ICU, respiratory fluoroquinolone, or a beta-lactam plus azithromycin.
In the ICU, usually a beta-lactam plus azithromycin or respiratory fluoroquinolone, considering broader coverage, including S. aureus.
And for hospital-acquired pneumonia, especially late onset, or with risk for multi-drug-resistant organisms, often needs a potent anti-pseudomonal beta-lactam plus an anti-pseudomonal fluoroquinolone or an aminoglycoside.
And if MRSA is a concern in pneumonia,
Add vancomycin or linezolid, but crucially not daptomycin. It's ineffective in the lungs.
good point. What about complicated intra-abdominal infections?
Mild to moderate cases might get cefoxitin or metronidazole plus another agent like cefazolin or ceftriaxone or Cipro.
High risk or severe cases? Maybe a carbapenem like imipenem or meropenem, or piperacillin tazobactam or metronidazole, plus an anti-pseudomonal cephalosporin like cefepime.
Targeting broad anaerobic and gram-negative coverage. If MRSA is a concern here, add vancomycin.
Lastly, common skin and soft tissue infections like cellulitis or abscesses.
Caused by S. aureus or strep pyogenes. For non-MRSA, maybe dicloxacillin, cephalexin, clindamycin, or nafcillin.
If MRSA is a concern,
Clindamycin, vancomycin, linezolid, or TMP-SMX need specific agents against resistant strains.
it's profoundly important to remember these are general guidelines for immunocompetent adults with normal organ function.
And local antimicrobial susceptibility profiles, local resistance patterns, can and frequently do influence the final choice. Constant adaptation is needed.
Beyond antibiotics, there's sometimes a role for adjunctive therapies.
Yes, treatments given in addition to antimicrobials, like intravenous immunoglobulin G, IVAG, pooled from healthy adults, providing broad antibodies.
Or hyperimmune globulin, prepared from individuals with high titers of specific antibodies.
Right. Used for passive immunity against cytomegalovirus, hepatitis B, rabies, vaccinia, tetanus, varicella zoster, botulinum toxin.
IVAG is sometimes used for suspected staphylococcal or streptococcal toxic shock syndrome.
Yes, though data suggesting efficacy are limited, thought to help neutralize bacterial toxins.
Beyond treating the individual, physicians must also think strategically about halting the spread infection control.
Absolutely imperative. When evaluating a patient, the physician must immediately consider what infection control methods are necessary to prevent transmission.
Protecting healthcare workers and other patients.
Exactly. The CDC published detailed guidelines for isolation precautions, standard, contact, droplet, airborne, widely available online.
This proactive approach also extends to post-exposure prophylaxis.
Right, aiming to prevent disease acquisition in individuals after exposure, but before symptoms develop.
Crucial for pathogens like Neisseria meningititis, HIV after occupational exposure, or Bacillus anthracis after potential bioterrorism exposure.
It's about being incredibly proactive, administering medication to prevent infection taking hold.
Finally, let's address a critical aspect. Knowing when to call for backup, the invaluable role of an infectious disease ID consult.
Yes, the ID specialists. Multiple rigorous studies have compellingly demonstrated that an ID consult is consistently associated with improved patient outcomes.
Shorter length of hospital stay and decreased overall costs for patients with various complex infections.
The benefits are truly quantifiable and profound. For example, that prospective cohort study of patients with Staphylococcus aureus bacteremia.
A serious bloodstream infection.
ID consultation was independently associated with a remarkable 56% reduction in 28-day mortality.
56% reduction. That's powerful evidence.
Undeniable. Beyond direct patient care, ID specialists provide other essential services that benefit patients and the healthcare system.
Like leading hospital infection control efforts, antimicrobial stewardship programs.
Managing outpatient antibiotic therapy programs, developing occupational exposure programs for healthcare workers. Their expertise permeates the system.
So specific clinical situations that absolutely might prompt a consult.
Difficult to diagnose patients with presumed infections, especially when the cause is elusive or the presentation is unusual.
Also when patients aren't responding to treatment as expected.
Indicating a potential resistant organism, wrong diagnosis, or underlying issue. Patients with a complicated medical history, organ transplant recipients, the profoundly immunosuppressed benefit immensely.
Their infections are often complex and atypical.
Exactly. And of course, patients with exotic diseases, those not typically seen locally or that are rare, would undoubtedly benefit from an ID specialist's deep expertise.
They are, in essence, the ultimate microbial detectives.
That's a good way to put it.
So what does this all mean for us? We've journeyed together from the historical misconceptions of bad air to the incredibly complex, dynamic, modern understanding of microbial life.
And its profound, undeniable impact on human health.
We've seen how diseases respect no borders, how their global reach is amplified by our increasing
Through
interconnectedness.
travel and trade, yeah.
We've peered into the fascinating hidden ecosystem within our own bodies, the microbiota, and understood how even our beneficial microbial residents can become foes.
Under certain circumstances, yes, the balance is key.
And we've walked through the meticulous diagnostic and strategic treatment approaches that medical professionals, armed with this profound evolving knowledge, employ every single day.
To wage this unseen war.
The ultimate takeaway here is not one of defeat, is it?
No, not defeat, but one of profound respect for the astonishing adaptability of life on a microscopic scale.
The study of infectious diseases is, at its core, a study of host microbial interactions.
Representing an endless evolutionary struggle in which microbes have generally, and often incredibly, been more creative and adaptive than we are.
Given that nearly 1/5 of deaths worldwide are still related to infectious diseases.
It is abundantly clear that the war against infectious diseases has not been decisively won. A cure for HIV infection is still lacking.
Only marginal improvements in TB detection and treatment after decades,
New infectious disease outbreaks continue to emerge with alarming regularity.
and the threat of microbial bioterrorism remains an ever-present concern.
This ambitious goal of virtual elimination will likely never be fully attained, precisely because of the rapid adaptability and sheer evolutionary genius of microbes.
The ultimate provocative thought for you to carry forward, then, is this. In this ceaseless evolutionary arms race, what new adaptation, what ingenious countermeasure might the next pathogen unleash upon us?
And how will humanity, armed with this ever-deepening knowledge, this relentless curiosity, and this profound understanding of our microscopic adversaries, respond?
This deep dive is truly just the beginning of mastering this complex and crucial field, and we encourage you to keep asking questions and keep exploring.